I now invite all of our panelists to join us. There's no better way we could have kicked off this conference than this Power Pack session this morning. We've seen a lot of really great questions and comments come through the Q&A box as well as the chat. But I would really like to kick off our panel by getting our audience involved. Hopefully everyone has had a nice balance of coffee as well as relaxation techniques with Dr. Gumidiala. So I'd like to pose a question to the group. And I think this will generate some discussion around a lot of the questions that came through regarding Dr. DeLay's presentation. So this is a case of a 33-year-old male diagnosed with eosinophilic esophagitis based on symptoms of dysphagia, endoscopic appearance with rings and furrows and exudates, as well as stricturing, and histology with 73 eosinophils per high power field under the microscope. The patient was started on a twice daily high dose proton pump inhibitor, didn't really have any concurrent heartburn, and at follow-up endoscopy 2 months later, his symptoms had improved by over 30%. The endoscopic appearance of the esophagus had improved, and biopsies showed that the patient had 17 eosinophils per high power field. So if you were seeing this patient, what are the things that you would recommend for this patient next? Sounds like he's doing better, no change in therapy, just continue the high dose PPI. Should we decrease the PPI to 20 milligrams twice a day? Should we change to topical steroids, or should we add dairy elimination? So please take some time to think about this question, think about Dr. DeLay's presentation, and enter your selection. Dr. DeLay, as we're seeing some of these responses and waiting for some of these responses to come through, some of the interesting questions that this question raised are approaches to therapy. And one of the questions posed throughout the presentation was, should we be doing upfront kind of multimodal medical therapy? And where does dilation fit in that? Or should there be kind of a more stepwise response, kind of stepwise approach to treatment where dilation is reserved after medical therapy has been maximized? Can you kind of give us your thoughts as we start to see some of the audience responses come through?
Yeah, sure, no problem. So I think it's, of course, patient dependent, but generally we want a systematic approach to this. And so kind of one treatment after the other instead of doing all treatments at one time, steroids and PPI, and potentially some diet elimination. And basically in doing so, you're trying to isolate which intervention is actually going to help the patient or which intervention works. If they started on an elimination diet with the PPI and you did an endoscopy that showed histologic improvement, you really wouldn't know, and it's probably rather a combination of factors, whether PPIs alone would help or not, or elimination diet alone would help or not. Dilation fits in when you have a situation where symptoms are persistent, but you see endoscopic and histologic improvement. But you can imagine then that there's probably some scarring or fibrostenotic disease that a dilation would be recommended at that time.
That makes sense. Christy, maybe we can start seeing what our audience thinks. And it really is the spectrum of options here. Dr. DeLay, what's your answer to this question?
So basically, because we're looking at the three parameters, clinical or symptoms, endoscopy, and histology, this patient is showing improvement in all three of those realms. Even though our histology shows 17 EOs per high power field, that's very close to that line for what we consider to be histologic remission. And given that the other two parameters have improved pretty markedly and to an acceptable level, I would say probably either A or B, honestly. No change to therapy. You could continue high dose, or you could potentially wean that dose and see how the patient does. You know, based on what they're reporting and what I'm seeing on the endoscopy and pathology, I wouldn't necessarily feel like I needed to change therapy at that time, unless something got worse, symptoms primarily, to switch therapy.
That's a great question. It sort of brings up a point that was also raised in the chat, and that is, for patients that are feeling better, how long do you continue to monitor them? At what interval? What testing do you use to kind of keep track of them, or really just based on symptoms?
That is a great question, and not one that I think that we have a great answer to. I think it depends on the patient. We know that we probably should be doing endoscopy after a change in treatment, but in patients who are clinically, endoscopically, and histologically in remission, it's kind of based on symptoms alone. I generally see these patients, depending on what their schedules are like, every 6 months, every year, just to check in and make sure it's going okay. Sometimes symptoms will creep up on them slowly, but if they can't get a clinic appointment for 3 months, now it puts us in a tough position. So I'll regularly schedule that appointment just to make sure that we're doing okay, not necessarily recommending a yearly endoscopy or anything like that.
Not so much for this patient who responded to PPIs alone, but in general, how long do you keep people on treatment? And which ones do you keep on treatment forever? Which ones do you consider kind of de-escalating treatment?
Another great question. Again, we don't have a good answer for that. But some of those patients, as I outlined in the lecture, that we might want to keep on, those who have had recurrent symptoms immediately after stopping, or some sort of complication or some sort of comorbid condition that puts them at increased risk for endoscopy. So we want to keep them on therapy to reduce those risks. Often patients will be the ones to tell you when they want to get off of therapy or try something new. And I think that is reasonable as long as they understand the risks of going off of therapy, that chronic inflammation that's not treated over time can lead to esophageal fibrosis and narrowing, and may end up requiring multiple serial dilations. So even though there's this theoretic risk of topical steroids, and there's certainly a risk of oral candidiasis with that, we do keep people on long-term steroids, particularly children who have been on steroids for a long time. And there isn't really a time when we have to stop it, as long as they know the risks of continuation.
It sounds like shared decision making is a big part of your practice, especially where there's these voids in long-term outcomes and data.
Exactly. And hopefully some of the biologics that are coming out will change some of this practice. We'll have a little bit more hard guidelines on when to start and stop.
That's great. This is a question for both you and Dr. Scott. Can you tell us a little bit about this phenomenon of lymphocytic esophagitis, and where do you see that falling on the spectrum of inflammatory bowel disease versus allergic mediated disorders like eosinophilic esophagitis? Admittedly, I have no idea where it falls on that spectrum.
Well, I'll let Dr. Scott speak to the association with inflammatory bowel disease, but there's a lot we don't know about lymphocytic esophagitis. And at this point, it is considered to be, while there's a lot of overlap in the endoscopic findings and the symptoms of both, doesn't appear to be the exact same disease process. So it doesn't appear to be on the spectrum of EOE. And interestingly, it's less associated with atopic conditions. And so that's one branch point of lymphocytic esophagitis with EOE. It's actually also more common in females than males. So there's a lot more that needs to be done about that. They can be treated the same, but we just don't know a lot about the connections between the two, other than that there is a clear connection we know with lymphocytic esophagitis and GERD.
Coming from the IBD side of things, I think a careful assessment for signs and symptoms that may indicate whether or not there's other areas of inflammation with the GI tract is probably appropriate. We do see upper GI involvement in about a third of patients with Crohn's disease. There was one sort of famous case series where they just performed EGDs on a bunch of Crohn's patients and found chronic inflammatory features in the esophagus or stomach or small intestine in 30% of people, which is pretty significant. The vast majority of these patients will not have symptoms related to that upper GI involvement, but if there is evidence of other GI tract location inflammation, then sometimes these patients will respond to IBD-directed therapies as well.
Thank you. And Dr. DeLay, you did an excellent job explaining the data. I just wanted to re-highlight this graph that you projected during your presentation, given one of the questions that came up. Can you walk us through this a little bit again?
Of course, no problem. So UNC basically conducted a study that took patients with eosinophilic esophagitis and put them on a treatment of topical steroids for 8 weeks. And then depending on that endoscopy, whether they had histologic response or not, which was less than 15 eosinophils per high power field, they divided them into these 2 responders and non-responder categories. And when they looked over the next 24 months at these patients, and how many dilations they required, they found that the histologic responders, so the folks on topical steroids, had far fewer dilations than those who didn't respond. And so essentially this is highlighting that patients who are on therapy benefit for many different ways, but also for that fibrostenotic disease, decreasing the need for dilations. And so the 2 should really be prescribed or recommended together.
Perfect. Thank you so much. So to switch gears a little bit, I'd like the audience to again help us spark a discussion around the brain-gut connection. So which of the following patients would benefit most from cognitive behavior therapy for disorders of the gut-brain interaction? The patient with body dysmorphia and an eating disorder, patient with a history of being abused as a child and trauma, patient who's angry with us because we won't refill their narcotics, or a patient who's worried or preoccupied by symptoms of bloating. And as these poll questions start accumulating, I'd like to ask Dr. Gumidiala, there was an outstanding question put in the Q&A box about the seeming importance of multidisciplinary management of these patients to offer kind of the full spectrum of services. We certainly are lucky to have you here at the University of Colorado. What advice or guidance or resources would you give to primary care colleagues, providers in the community who may not necessarily have immediate access to a GI psychologist as we do down the hall? What guidance would you give to them to incorporate some of this practice for their patients?
Yeah, that's, I think probably the case for a lot of GI practices, and definitely in primary care clinics as well, that there just might not be that access to a GI psychologist or a GI mental health provider. And I think a shameless plug would be to recruit a GI provider, excuse me, a GI mental health provider for those clinics. There's just so much literature, both in the primary care world and in other specialty medical clinics, making the case for having a psychologist, for a clinical health psychologist, especially in these settings, to really help patients with those different conditions that they're dealing with. So, of course, that would be the ideal, to get a mental health provider on board. But of course, if that's not possible, I think connecting with providers in the community can be really important. So being able to see who's out there and who can provide some mental health services to patients in the primary care clinics or in our GI clinics can be really helpful. There are some resources. The Rome Foundation has a gastropsych section, and it's fantastic and very robust. And they've done a lot in these last couple of years to really bring education to general mental health providers so that they can provide these kinds of interventions for GI patients, even if they're not located in a GI clinic or even in a primary care clinic. So there's been tons of training out there for mental health providers, and they also have a directory where you can look up to see if there are GI specific providers in the area. So that's one thing that I would recommend. And then I also think that just in general, if you're not able to find a GI specific mental health provider, the next step would be looking for a health psychologist. So, health psychologists will work in lots of different medical settings. And of course, these interventions that we're using can be tailored to a lot of different medical conditions as well. And so somebody who has that training and has that experience working with different medical issues in different medical settings would also be really great for our GI patients as well.
Thank you. I'll ask Christy to see what our audience thinks. And in the interim, I hope, Dr. Mediala, you don't mind if I volunteer your contact information to anyone who might be interested in learning more resources. So please, those in the audience who would like to learn more about the type of work that you can incorporate into your practice to bring this mind-gut connection together, please don't hesitate to contact us and we can connect you. And so it looks like most people agree that the patient who might benefit most is the one preoccupied with these symptoms. So I appreciate you driving that message home to our audience about the patients who would benefit most from a referral to you. We have time for one more audience response question. And so Dr. Reveille talked us through a very complicated, but in the end, maybe not so complicated case. Let's see what the audience thinks about etiology of esophageal strictures, one of the most common things that we encounter when we do routine upper endoscopy. And so as answers start to come through, when they start to level off, Christy, feel free to project those. But as we await those, Dr. Reveille, what does this question trigger for you?
It's called thinking outside the box, buddy. And the case was a very illustrative of a group of very smart people doing their trade, and we all had this traction bias of thinking this was all about acid reflux. And clearly acid reflux is probably the #1 cause of esophageal strictures, hands down, because of the underlying prevalence of the disease. I mean, 40 million Americans have acid reflux disease to some degree. But beyond acid reflux, I think the key in this story was, in the background was this developing achalazic syndrome. And we saw distal strictures first, but not at the GE junction. And that's probably where early on this NSAID, this meloxicam, was frequently found to sit for hours at a time and create mucosal injury. As you saw later in the case, the strictures became quite proximal. The distal disease was dealt with, it never relapsed, and now we're dealing with proximal esophageal strictures. And I imagine that the fluid column that this patient was complaining of was getting higher and higher with time and leaving that meloxicam sitting in the proximal esophagus. That's conjecture, but from a physiology standpoint, I think that's actually what happens. So I think you should think about NSAIDs and other related medicines. Obviously, we know about strictures with tetracyclines. We know about strictures with potassium chloride. Some of the SSRIs, SNRIs have been implicated in both motor disorders and in esophageal injury, non-achalazic. So we need to think outside the box when a simple peptic stricture, which ought to respond to dilation and appropriate acid reduction therapy, the relapse rate is actually very small. It's 10% every 2 years in someone who stays on a PPI after a peptic stricture is dilated. So we need to go beyond that. I think Kelly's description of the role of eosinophilic esophagitis in causing strictures at all levels and often throughout the entire length of the tubular esophagus always needs to be kept in mind. And that's why at index endoscopy, even if the esophagus doesn't look particularly strictured, we might want to think about biopsying for EOE because it's going to complicate matters and you're going to be prone to, and you can guarantee relapse of symptoms over time. So I think the answer here is pretty clear that there's more than just acid reflux disease that causes strictures. And as you recall, his pH probe was entirely normal, off of treatment for a week, which is our standard. And it turned out that we could see the retrograde boluses related to his developing achalazic syndrome. He did not have acid reflux causing all of this.
Perfect. Thank you, Dr. Reveille. Continued reminder, especially in our fast-paced open endoscopy blocks, to keep our internist hats on and take thorough histories, medication histories in particular, and realize that oftentimes some of our interventions can precipitate ongoing symptoms and issues down the line. We have had outstanding questions, comments that have come through the chat function, the Q&A function. I would like to give everyone the promised break, but rest assured that our speakers will continue to interact with you and continue to respond to these questions through the chat function. But for now, we will break until 10 a.m., where we will reconvene for this session that we have planned in hepatology. I want to thank all of our speakers and our audience for this excellent session. Couldn't think of a better one to kick off this conference this morning. Remember, free registration and continuing education credit wouldn't be possible without our generous sponsors. So please take the time during this break to visit the virtual exhibit hall. You can view customized content from them to kind of get a sense of what their offerings are. And we will see everyone back at 10 a.m. sharp. Thank you very much.